Okay, so our next speaker is Dr. John Viskovich. He's the podiatrist in our group Westchester Health, and he's been in practice for 13 years, has offices in Mount Kisco and Yorktown. He's going to talk about common foot and foot issues in children, adolescents.
Good morning, everybody. First of all, I want to thank Eric for having me, and I want to thank everybody for being here. I know it's early in the morning. I'm here to talk about a lot of things about the foot. Please forgive me. I am a procrastinator. My slides and my papers are probably coming from my trusty office manager as we speak. So try to follow along with me. Okay. I'm going to talk about some things in the pediatric population, basically infants, that we should be looking out for. And we're also going to be talking about things that are really common that often get overlooked. First thing I'm going to talk about is something I see quite often. It's toe walking. I'm going to tell you, my wife is, well, I'm not going to tell you her age, she'll kill me, but she still walks around the house up like this. It's the funniest thing. It's known as idiopathic toe walking, right? Why it happens, a lot of times we don't know. It's usually habitual. It usually gets grown out. They usually grow out of it, but there are several reasons for it and things that we have to watch out for. One, being a tight heel for it. The other one, in very, very rare cases, something that goes misdiagnosis, rare mild forms of cerebral palsy, a little contracture of the other thing. There's also some types of congenital bony blocks. In other words, it's bone blocking the movement of the foot. Sometimes it's some proprioceptive disorders, just general dysplacatonia. But what do we do for it? Achilles tendon stretchings. Orthotics are not really. It's more for the proprioceptive patient, and I'll use the orthotics. For the true toe walker, it cannot be treated conservatively. There are posterior capsule releases, and in that case that I feel a little suspicious was just to say something that Ron said, refer it out. It doesn't hurt. What if it is that mild form of CP that wasn't seen? Refer it out. Can't say that enough. Another thing that goes really undiagnosed in the child, the infant population, and it's one of my little peeves that I have a lot of parents come into me and they say, was there something I could have done about it? There's a thing known as metatarsus adductus. I call it the intrauterine unwinding. Intrauterine, the fetus is like this and unwinds. A lot of time, that foot doesn't unwind. So as opposed to having a foot like this, you have a foot like this. And what happens? You're walking pigeon-toed, in-toeing. You get tripping. It also can be congenital. It also can be part of a clubfoot, not a major clubfoot that everybody sees right away. The thing about these things is they're really, really, early recognition is such key. Serial casting in an infant gets that out right away. And that has to be seen 1, 2, 3, 4 months. It's not a bad idea just to have a look at it. There's night splints. That's a great night splint. It basically takes the foot and it splints it this way. So your heel is pointing that way and the rest of your forefoot's pointing this way. Gets it out really good. There is a surgical release, again, for the most serious forms. Very rarely it's done. Years ago, it was a bony release, but in the infant population, it's all a soft tissue release. So it's not even anything that you got to do any break bones. Later on again, with the metaductus, a lot of people get flat feet because it's usually just it's not just a one-dimensional thing, it's a three-dimensional thing. So if it's this way, it's also that way and that way. So what happens is the whole leg turns in, you get a little flat foot. Later on, if just a little support for orthotics, that's about it. Next thing, it's another thing that people have to look out for. This is again in the infants. Femoral anteversion. I always say, beware the newborn that's walking with not bow-legged. Your first steps are always bow-legged. If you get a newborn that's walking like this, you got to be a little careful about that. Newborns should be walking like this, flopping around like that. So you have to be a little careful of that. Awkward gait. You're going to see in-toeing with that as well. And again, flat foot. I'm going to mention flat foot a lot. Flat foot's a topic unto itself. Again, what we do for that, we see that a lot in the 8-year-old, 9-year-old, 10-year-old patient. You have tight external rotators. Again, it could be congenital. In the most severe cases, there are also femoral osteotomies to correct that. Now I'm talking about a lot of things above the foot, but the foot is the great adapter. The foot takes all the turns and twists of your body, upper back, so it affects the foot. This is nothing I would do, but again, you have questions, the pediatric orthopedist is a great, great consult. I'm not that either. Tibia Varum, bow legging, all right? Again, all these things kind of lead to a certain type of flat foot, tripping, awkward gait, like duck gait, where the foot all the way out, like at the 45-degree angle where you should be at 15 degrees. Again, could be congenital, also could be some malnutrition, but we don't see that in that country. Almost always structural. Again, in the most severe cases, there are wedge osteotomies of the lower leg, and again, orthotic therapy. But the orthotic therapy, again, in this, it's more accommodative. You're not trying to change the function of a foot, you're trying to accommodate it. There's a few other things, you know, I just put this slide up, like in-toeing, a curved foot, forms of club foot there, not really that much there. As Ron mentioned, there's Sever's disease. I see so much of this, it's incredible. Almost always associated with activity. A lot of activity, no rest. Get kids, I usually find it to be bilateral. The most important thing about Sever's disease you have to remember, it's going to be pain in the heel. Almost every case will get better. We talked about rest. Rest is so important with this. You have to rest. Unfortunately, most of the time what we see in our population around here, kids don't rest. What I do find, the kids that don't rest, every once in a while, if that pain is of such a long-standing nature, I will get an MRI. I will find stress fractures in them every once in a while. But it's an inflammation of the growth plate. You should know, bone grows faster than the soft tissue. And that kind of doesn't make sense, but the bone will grow very fast. It takes a while for the soft tissue to catch up. So, not enough rest. Again, tight heel cords and hamstrings. Also, we use heel cups. It's not orthotic. It's a hard heel cup. It protects that growth plate. Passive PT regimen, warm up. Nobody warms up anymore. I have twins. I get crazy, and I'm going to talk about that next. Nobody does warm up. Which leads me to equinus, and I see so much of this, and I do call this the root of all evil. Equinus is the root of all evil. It's basically tightness. I get kids in my practice. My foot hurts. My toes hurt. I put them on the table. I do an orthopedic exam. I get their foot maybe to 90 degrees. I get their hamstrings 45 degrees before they engaged. The kid who's 8, 9 years old, I should almost be able to get his legs perpendicular to his body. It just doesn't exist. Tight hamstring. Tightness all over. It's just the lack of stretching, lack of warming up, lack of stretching, lack of cooling down. It's associated with a flat foot because when you have a tight heel cord, what happens is you pick up the heel a little bit earlier and you have a breakdown in the midfoot. Leads very easily to strains and sprains as well. Sometimes congenital. As I mentioned before, it could be bony blocks, capsular releases. But in the population around here, it's just kids don't warm up. That's all it is. We need to have our trainers and coaches spend time with warm-ups and cool-downs. Parents definitely need to be educated. A little bit of physical therapy routine. The other thing I like to say is the Xbox stretch. All right? And it's kind of like my term, and I tell this to kids all the time. I know if I'm watching TV, I'm stretching all the time. You know, put the kids in a position where their legs are 90 degrees while they're playing Xbox. That's a stretch. You know, have them put their legs up over here with no support. That's a stretch. You know, just these little Xbox stretches when they're sitting around. I was stretching in the back here. You have to stretch all the time. Flat foot. Okay. Why do we treat flat foot? When do we treat flat foot? What happens is with the collapsed heel, you can see there's internal rotation of the knees, of the hips, extension of the lower back, sometimes a little bit turn on the shoulders. So the foot, when it is truly a flat foot, without any of the other factors, does affect the knees, does affect the hips, the lower back. There's certain types of flat foot. There's a flexible versus a rigid. Rigid is usually because of bony blocks, coalitions. It's also due to low tone, a lot of ligamentous laxity. Kids with Marfan's have flat feet all the time. You see an awkward gait. It's not always painful. I always tell this story. One of my drug reps, she had a foot as flat as a pancake, and she was the Texas State sprinting champion. You would never believe it. Doesn't always have to be treated, you know. So it's not like you have to say, "Hey, you got a flat foot, you got to do this." When to treat? You treat it when there's pain, when there's obvious gait issues, when you see associated deformities. You know, kids shouldn't have a bunion at 8 years old. Hammer toes. I also stress flat foot orthotics, and here she is. Okay. She's got my hand out now. So flat foot does not always have to be treated. I always tell my patients, orthotics are glasses for the feet. All right. You take your glasses off, your eyes don't work. Right. Glasses are not changing your eyes. Put your glasses on, guess what? You can see. Orthotics make your feet work better. That's all they do. Anybody who tells you an orthotic is bracing your foot and changing your foot, they're lying. It doesn't. When a person grows out of a flat foot, which we see most of the time, it's because they were going to grow out of a flat foot. We put it in there just to make the foot work better. And I stress that all the time. I'm very, very big on team effort. I can give you an orthotic, but if you don't stretch, if you don't take care of it, if you don't use it, so half the team is not working, doesn't pay. Why do we treat it? Maintain proper body alignment, prevent that lower back, hip, and knee pain that I talked about, decrease wear and tear of the lower extremities and all the joints associated with it. In the most extreme cases, there is flat foot surgery. What you're doing here on these surgeries is basically where you see those two screws in the back. Again, forgive me for not having these out yet. Basically, you're sliding the heel inward. Where you see this staple over here, you're actually putting bone on the side of the foot to lengthen the outside. And over here, you're fusing a joint together. So you're creating a heel in, elongated outside, and a plantar flex first ray. So you're creating an arch. Often that works great. And that's what the flat foot surgery looks like. Not all of them are like that. That's everything. Sometimes you only do one procedure. Sometimes you do three. There's also a procedure out there where you can stent the sinus tarsi. Moving to a little older population now. Things that really you do see in the practice, and these require such high levels of suspicion, and they're really, really important. Freiberg's infarction, as Brian was mentioning, is growth plate issue, basically. It's an avascular necrosis of the second metatarsal head growth plate. Very, very high level of suspicion, especially in a female who's very active, has got a swollen joint. It's painful though. It's basically a break in the growth plate. If that's not treated, you will have problems later on in life. And I'll show you a slide later on what happens. Pain will go away if treated not properly, but it's going to take time. Because you can go through it, but the MRI is kind of showing there that here's a growth plate. If you look at this, you can see how nice and white that is, Look at over here. The capillate fragment, or the metatarsal head, is inflamed. That growth plate lacks blood supply. And that's one of the big problems in the foot. When we talk about the calf, we talk about the thigh. These are huge muscle groups that supply the bone. In the foot, the vascular supply to all the bones in the foot can be compromised so easily. I'm going to show you another one. That's basically what happens. And really, the only thing you can do with a Freiberg, and it is confirmed, diagnosed and confirmed with MRI. You have to immobilize it for 4 to 6 weeks. You do take serial x-rays in order to make sure that everything's healing. Physical therapy to start off, because you'll get a lot of fibrosis in that joint from the stiffness. Accommodative orthotics. When I talk about orthotics for flat foot, this is different. I'd be offloading that second metatarsal head. Make sure there's not pressure put on there. And NSAIDs. Koehler's disease is another one. A kid with midfoot pain that's unexplained, you have to have a high level of suspicion of this. I recently treated one of my friends who's on the football team. Thank God it wasn't it, but I had to convince them to go for a CAT scan and an MRI because the kid got pain out of nowhere in the midfoot. The navicular is a midfoot bone, and again, very, very low level of blood supply to it. They undergo like an aseptic necrosis. bone just dies. Blood supply, could be trauma, it's got to be recognized. If you don't recognize it, what can you have? A lot of long-term sequelae. Basically, a lot of midfoot arthritis. And what can you do? You got to be casted. Have to be casted for 4 to 6 weeks. Long-term neglect leads to midfoot arthritis later in life. May eventually, again, later in life, require midfoot fusions. And I put that in bold. So much of the stuff I see, and I try to stress to my parents, it's like, if you don't treat it now, you'll probably be better in a week. I don't know what you're going to be in 20 years. You know, I think Dr. Mann said, if it hurts, stop the kid. It just doesn't pay to say, oh, push him through. It just does not pay. Coalitions. Coalitions, something you see a lot more frequently than you would imagine. Basically, in our population, youth population, they're mostly soft tissue coalitions, which as time goes by will develop into bony blocks. It's basically like they're cartilaginous. You don't always see them on x-ray. This is one that's really apparent on x-ray, where this bone and that bone are coalesced. They should not be together. Often missed on x-ray because you don't see them because they're cartilage. It's also associated with something we call peroneal spastic flat foot. When you have a coalition, the outer group of muscles are basically firing way too often because they're trying to reduce the pain that's in that area. Pain is also not always in the area of the coalition. So the big thing that I listen for is like, doc, I'm fine and I run for 20, 30 minutes, my foot's killing me, right? You immobilize it, you exhaust all conservative care, doesn't work, MRI, you'll see a coalition. Another little pearl I offer, establish a relationship with a good radiologist. I use one particular guy down in Hartsdale. I can talk to him, we can go back and forth, and we just, I say what I see, and you can send anything, and I'm not going to knock any radiologists, but the radiologists don't have the ability to have the patient in front of them. I get so many patients who say, how could the radiologist not see that? And I said, you know what, radiologist didn't have, you weren't sitting there with him. He couldn't touch you. He couldn't say, is the pain here? I can. Then I can go back to my radiologist. This is what I'm seeing. What do you think? Maybe there is something there. And so establish a relationship with a good radiologist. Something I often do, it's a few things I do. This is a real simple surgery. You take them out. They hurt, take them out. Years ago they used to do major fusions to kids. It's not necessary anymore. There's a little muscle group right there that we're retracting here. You elevate it. You go to the block, you take it out. And there's a rule of thumb in surgery, if you have to think about how much you take out more, right? There are also calcaneal-talar, which is a little bit more severe. They're often not diagnosed because you have a stiff foot, and if it's true fusion, it's a very stiff foot. Well, you usually find them, if they're painful, they require a fusion. They're a little bit different. That's where the heel bone is attaching to something above it. This one is where there's something attaching within the foot. Ron mentioned something about fractures, Salter-Harris fractures, right? Often misdiagnosis or undertreated in the foot. Again, long-term sequelae of fractures in the pediatric population is what I'm always concerned about. So here, this is a Salter-Harris 3 fracture. That's a big toe, right? Doesn't look like much, but what if this little piece over here dies off? You're going to have arthritis in that joint as time goes by. You're not going to know it in 2-3 years. You'll know it in 20 years, though. It's got to be treated. It's got to be immobilized. So a toe fracture is not always such a small thing. This is like for Salter-Harris, you have to cast it. Most of mine I don't have to cast. Sesamoid fractures I do cast. Accessory navicular, another one that you see a lot. It's usually a painful bump on the side of the foot, often associated with a flat foot. Very, very usual that it's amenable to conservative care. I maybe take 1 or 2 out a year, and we see a lot of them. The only time that when you take them out is you've tried everything, you've tried NSAIDs, you've immobilized them twice, you've tried shoe gear modification, you've tried orthotics, doc, it still hurts, take it out. It's a very, very simple procedure. You just go to that side of the bone, you excise this extra bone, put an anchor into that bone, and reattach the tendon. Orthotics, surgery. I wouldn't do my profession justice if I didn't mention the infamous paronychia, the ingrown toenail, all right? Often sports related. I call them the clandestine picker. I didn't pick that, Mom. I was like, really? Like the toe was like half gone, but I didn't pick it, it just happened. So, could be congenital, believe it or not. We get kids that have these toenails that are wider than their toes. They often have to be taken care of. It's a very simple in-office procedure that we do. One is the P&A, where as you can see, we're going in there and removing a piece of the nail permanently. It works. You have to do them over sometimes. Every once in a while, yeah. What you really got to be careful about, and whenever I get an ingrown toenail that somebody else has been there before, I get an x-ray. Why do I get an x-ray? You can get an osteomyelitis from these things if not treated properly. Basically, where this cotton swab is going in, it's touching a bone. And you know what? If somebody else has been there before, there's a chance that a bacteria was brought down there. I get the x-ray to have a baseline. Because you know what? 2-3 weeks from now, if it's still swollen, inflamed, I take an x-ray, and I've seen it. I've seen it in osteomyelitis there. 6 weeks of IV antibiotics for an ingrown toenail. So you got to take care of it. And then, my infamous wart. Again, I wouldn't be doing my profession justice without mentioning it. Warts like to swim. That's what I said. If I have 100 warts, 60 of them are swimmers. I don't know why, but they like to swim. They're painful in a lot of cases because of where they grow. They have a high propensity to spread. And sometimes it's good for me. When one kid gets them, the other kid gets it. So it's not a bad thing either. So it's very common for the siblings to get it. And the big question I get about warts is this: how do I prevent them? I don't know. I really don't, because I have moms come in, I Lysol the bathroom, I dip my kid in chlorine, it doesn't go away. And I really don't know. I tell people to spray Lysol on their shoes. Very important to change your shoes every day. Let them dry out. High propensity of warts in sweaters. That's why I think kids who sweat. So we see that a lot in the kids who just enter puberty. Very on the top of the hand, on the top of the foot, over-the-counter medications work great. On the bottom of the feet, they don't work at all. There are some salicylic acid products out there that I see parents over-treating the kids. I get infections about 4 or 5 a year where you get like cellulitis going up the leg. Just because you're putting too much medicine on a thing. Because I would do the same thing. Wow, that worked great. Let me put some more on. So, the key to treating warts, though, is debridement. I have a 5-step process that I use: debridement, freezing, icing. And then I have home medications. And that's some of the things that we see in foot issues in children and adolescents. So, lots of stuff going on, a lot of common stuff, a lot of things, high level of suspicion. And my pearl to you is watch out for what's going to happen 10 years from now. Keep that in mind.
Can we go back to the toe fracture?
Yeah.
Because for so many years it was like, well, they don't do anything for a broken toe.
It's not true, though.
So,
Yeah.
so we suspect a broken toe in a kid. They really should go for
Yeah.
X-ray and see an orthopedist.
Again, what's going to happen is 90 out of 91, you're not going to have to do anything. You're going to have to be careful for when it's in the growth plate, especially in the foot. Because the big toe, everybody knows it's just a toe. Every step you take, you push off with your big toe. Right? Kids, when I see a parent with arthritis, if I went back to the Freeberg's picture, you're going to see the second metatarsal. It's arthritic. What happened? The growth plate was damaged from Freeberg's. So put that into a broken toe in the first. If you break your big toe at the base of the big toe, that's where the growth plate is. That's a major joint for every time you walk. So if you start to get that arthritic, like I see that arthritic in catchers, 15, 16-year-olds. I've done decompressional osteotomies for 16-year-old catchers because they've got arthritis in those toes already. Just open up the joint, clean them up. A lot of times the arthritis is already started. And if you get arthritis when you're 15, 16, can you imagine what it's going to be when you're 30, 40, 50?
Yeah.
So.
And do you ever see severs or any other type of heel pain in a pre-K like a 3 to 4-year-old?
You do, but not that often. You know what? Again, when somebody comes in, if it's 3 or 4 years old, and they have heel pain,
Yeah.
you treat it like severs.
Right.
But you also have it in the back of your mind that that should get better, because a 3 or 4-year-old, they're active, but it's that exertion in severs. Kid who runs a lot, and it's really the growth spurt. So, and I'm trying to think of the ossification of the apophysitis. I don't think it's ossified yet there.
Mhm.
So I doubt it. Very, very rare, but I've seen heel pain in kids.
Yeah, because I had a pre-K the other day that
Mhm.
just had so much heel pain.
Yeah. So it also suspicion of Lyme's. And my dog had Lyme's. 21 days of antibiotics. Just finished it.
Just for heel pain lines?
Could be, yes.
Yeah.
Heel pain and Lyme's could be as well. Inflammation.
For the tight heel cords, do you do any of the like tendon lengthening procedures?
You know what?
Prefer
One thing you learn about surgery, you do what you're good at, right?
Yeah.
So that's when you say, let's go, let's send it out. So, do I know how to do them? Absolutely. As a podiatrist, we are somewhat limited because of state laws here. So, like, I'm allowed to do things, I choose not to, because it's like, I can diagnose this, I know what to do, and I know where to send you. I'm never afraid to send somebody out, because you know what? You gotta treat the patient right, so.
Back to severs. You mentioned breast. How long should the breast be?
For severs, I generally have patients rest 2 to 4 weeks. Eric, what do you do for severs?
That's a loaded question.
Yeah.
You know,
Everybody has their own treatment regimen for
you have
severs.
your 12-year-old who's playing free soccer.
Right.
So you would have them modify it. See if they rest, don't stretch and nothing. They're still going to have the pain. And are they limping? But we have them relative rest 2 to 4 weeks would decrease their impact at the running and the jumping, and the biking and the swimming, low impact stuff, do the stretching, and that calms it down. But a lot of kids, as John, Dr. Niskin has seen, or I've seen, they've had it for a year or 2 years. Oh, we rested for a week.
Yeah.
You know, but 51 weeks they're playing soccer and in cleats.
And that's the big problem with severs. Like I said, most of the time the pains go away, but I tell my parents, if you rest it for 4 weeks, it's going to go away, and you stretch it. But if you keep playing soccer, it's going to hurt. And I'm going to tell the story about one of my patients. I played hockey in college, and I had a kid with like a little fracture, secondary to a severance. And he was training, did lacrosse, his foot was killing him. And I asked him, I said, and he was going to a big hockey tournament out in Colorado. And I said, does your heel hurt when you play hockey? He says, no, go play, don't worry about it. So there's times you can let kids play, and hockey, why didn't it hurt when he was playing hockey? Because he wasn't slamming down on the foot. So I knew it as a hockey player, and that probably doesn't hurt you. I'm probably a hockey player mentality I have, but go ahead, play. So, it's like I got 15 stitches in my face. It's nothing. So, but any other questions?
Stretching. How long should you stretch? For each
I show patients about 3 stretches in my office, because I think the span of attention doesn't go past that. I want my kids to do physical therapy. And I want my kids to do physical therapy for at least 2 weeks. Why? Let the physical therapist who does that all the time, give him a good home stretching regimen. To really stretch out a patient, you're going to have to spend half hour with that patient. And in our economics, we don't have that half hour to do it. You do it in initial visits. You go through it. But you have to show the patients how to stretch. So you get 3 good stretches. That Xbox stretcher I told you about, that's a great way to stretch out your posterior muscle group. Just sitting there, how do you do it? Bend, have your leg up. Stretch that posterior muscle group as you're watching TV. I do it every night. So.
And what do you do if orthotics hurt? If orthotics, when that's not hurting?
Orthotics should never hurt. If they hurt, that means you got the wrong orthotic, right? Orthotics also, like I mentioned, rigid flat feet. Rigid flat feet tend to have orthotics hurting more, or, believe it or not, the picture I showed actually created an arch. You don't necessarily want to create an arch in every orthotic. There's certain kids that need to collapse. You know, in certain children's gait style, you need to collapse. You need to absorb shock. So now, if you have a kid that's just totally flexible flat foot, he's got a flat foot when he's on your table, he's got a flat foot when you stand. You don't want to make an arch in that kid. You just want to support what's there. So if you put an orthotic in that kid who's got a real flat foot, and you tried to create an arch, it's going to hurt. And that's when, and if it hurts, it should not hurt. An orthotic should never, ever, ever hurt. Anything else? All right, thank you.